You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 9th, 2023. Our topic is the evaluation of severe asthma presented by Dr. Jade Tam-Williams. She is an assistant professor in pediatrics at Children's Mercy Hospital in Pulmonary Medicine in Kansas City, Missouri.
All right, good morning, everybody. Welcome to Conferences Online in Allergy. It is October 9th, coming to you from Kansas City. Today we have Dr. Jade Tam-Williams, who will be speaking to us on the evaluation of severe asthma. Thanks, Jade, again for being back again. She's an assistant professor at the University of Missouri, Kansas City. She is pediatric trained in residency at WashU in St. Louis and then did her pulmonary fellowship there and then came to join us at Children's Mercy. Her interests are in severe asthma as well as childhood ILD. Thanks, Jade.
Thanks so much. I hope everyone can see my screen. I always enjoy coming to do these. I actually just did another talk with another cohort of allergists, and I always enjoy kind of seeing the other side of things. So this is always a little fun for me. So I will not be able to see your faces, so please raise your hand or scream at me or something. I'm totally fine with being interrupted if you have a question or if you have something in the chat box. So let's start with the disclosure. So the first thing is that I want to be very clear. I'm not an allergist. I'm a pediatric pulmonologist. And so I think that gives me a different kind of insight in regard to asthma. And typically I'm pretty skeptical about what we call one size fits all. And these are the funding that I've had in the past 24 months. And I think ultimately I'm a big fan of recognizing what's real and what's practical and what's ideal life or what's research life. In this talk, we're going to go through a couple of things, but mainly we're going to be doing a bunch of cases. And I think I'm trying to use cases to demonstrate to the team kind of how I think about the evaluation of asthma. So I hope that this will kind of give you some insight. For every talk, of course, there's a bunch of abbreviations. So here some of them are, in case you need to refer back to them. So I almost always start with this slide because I think if you know the definition of things, it really helps center you back, right? So, and I think if you've ever heard me talk, I almost always start with this one because I always say, like, what are we actually talking about? Okay, so asthma, as we all know, is a heterogeneous disease process. It has been around since the ancient Egyptians. It has many presentations and characteristics, and I typically liken this to the example of the 7 blind men and I think it's like the 6 blind men and the elephant. And because depending on where the blind man is touching, the elephant feels like something else to them. And that's kind of how I think about asthma, is that, depending on our personal lenses, we might see asthma a little bit differently. But the ultimate things that we all kind of go back to is that asthma is chronic. It is defined by airway hyperresponsiveness. That airway hyperresponsiveness is in the lower airway, and it is an obstructive process. It has to be partially reversible, and it is due to airway inflammation. And if you go back to that, I think that always, if you hold true to that, that always helps you figure out the definition of things. What makes it difficult in regards to asthma is the hyperreactivity to a variety of stimuli, its diversity in its clinical presentation, and the variability of its clinical course. And there's no one test, right? There's nothing. Parents are going to come to you and they're going to say, I want to know if my kid has asthma and I'm here for the asthma test. Well, there's no asthma test, it's you have to meet with a doctor who's seen a lot of asthma, and that's how you get your diagnosis. So what about pediatric severe asthma? So according to the International Study of Asthma and Allergies in Childhood, the global prevalence of severe asthma in adolescents is 6.9%. This range is anywhere between 3.8% in the Asia Pacific. to 11.3% in the United States. The other cohort that we look at is the SARP-3 cohort, and this is the Severe Asthma Research Program cohort. This was a 3-year study looking at about 188 children, and they compared about 111 severe to about 77 non-severe, and then about 500 adults, 300 of which were severe and 200 of which were not. And they essentially said, hey, children typically have higher eosinophils, they typically have more allergen sensitization, and they have higher IgE than adults, and that children with severe asthma compared to children who did not have severe asthma typically had more symptoms, more exacerbations, but they really didn't see a ton of difference when it comes to BMI or lung function, and that typically children have relatively normal lung function. But what we all know kind of from our clinical experience is that severe asthma patients are the minority of patients that account for the majority of morbidity, mortality, and healthcare costs, with estimates up to about 60%. So this is the definition for severe asthma from 2014. I like this one because I think this is pretty specific, okay? So the first is that it's important to note that this is for those over the age of 6. The second thing is they use the GINA guidelines. They say step 4 or 5, so a high-dose ICS with a controller, or a singular or theophylline, or you're steroid dependent in order to keep you controlled. And they define control with using, in our case, we use the asthma control test, 2 or more steroid exacerbations, severity of exacerbations, which gives you some insight into mortality risk, and then airflow limitation with the FEV1 being less than 80% in the face of a lower FEV1 over FEC, and that, or they say you have controlled asthma, but as soon as we taper down, things go badly. And I want you guys to know this because this is actually what one of our definitions for use in Air Clinic. If we are to see a patient in Air Clinic, we follow these exact guidelines. So it's helpful to recognize the difference between uncontrolled, difficult to treat, and severe. And I like this. This is from the GINA Severe Asthma Pocket Guide. This little chart right here, I don't know if you guys can see my mouse or not, but they say how many people with severe asthma, and they say, okay, out of 100 people with severe asthma, these are adults over 18 and from a Dutch survey, so to just be clear, about 24% of these individuals are in step 4 or 5, but out of those 24%, maybe 17% are difficult to control. They are in step 4 and 5, and they have poor symptom control. But then only about 3.7% is with GINA step 4 and 5 with poor symptom control and with good adherence and good technique. And I think that's a good way of thinking about these kids too. So you can say, hey, how many of these kids are uncontrolled, and are they uncontrolled based off of frequency of exacerbation, mortality risk, or morbidity risk? Are they difficult to treat? And this may be, they're difficult, they are on those high doses, but maybe they have other risk factors that are modifiable, or maybe their diagnosis is just wrong. And then finally, are they truly severe asthmatics that they are uncontrolled despite the fact that they're using their treatments and they're using it correctly? And I'd like to put some context within this. So when we first created the Air Clinic, this was the data that I was kind of gathering. And I think it kind of gives a sense, and I think it's pretty still relevant now, even though the data's older, but it gives you a sense of what are the types of asthmatics we are seeing here at Children's Mercy. So this is in 2015, and we looked at all children with a primary diagnosis of asthma that had come through Children's Mercy's doors anywhere within the system, and this was about 7,115 kids, so about 8,000 kids. Out of those 8,000 kids or so, only about 5,000 had an asthma action plan that we could actually look at their what they were prescribed. And out of those asthma action plans, about 5 on that high dose ICS. So only about 5% of these kids are actually on the GINA step 4, step 5. And then it got kind of complicated, right? So out of this group of kids, there were some groups that were part of the high-risk asthma program. The high-risk asthma program is defined by children who have 4 or more ED, urgent care, or hospitalizations in 12 months, lifetime, once ever in the lifetime of ICU admission or needing intubation and or cardiac arrest from asthma. And looking at this group, what's interesting to know is even though we saw 106 of them, only about 40% of these kids were actually on step 4 or 5. The remainder were actually kids who were just seeking care frequently. And so that kind of helps you think about morbidity, mortality, and or is a kid both high morbidity risk, high mortality risk, or are they both high morbidity and mortality risk? And within this group of overlap of children, those are the kids that we're looking to fill AIR up with. And AIR Clinic sees allergy and pulmonology. We are in the process of looking for a nutritionist, but we also have social work, environmental, and we have a psychologist. And I always tell all the residents, I say, the first question to ever ask yourself, if you get a chief complaint of severe asthma, difficult to treat asthma, is this actually asthma? There was one review article that found that the misdiagnosis of non-asthmatic conditions as uncontrolled asthma was anywhere between 12 to 30%, and the differential diagnosis for severe asthma in children is really extensive. So it can be all of these things that I have listed here on this little slide. Or even worse, it could be asthma and one of these other things, which can make it difficult for management. This is what I call the 6 steps. So you only have 6 steps to evaluation of severe asthma. We're really pretty much going to go through the first 4 steps at most. But the first step is really confirm the diagnosis. Then the second step is identify your comorbidities, optimize management, reassess, assess your phenotypes, and then considering other types of therapies. And then it's always reassess, reassess. For history and physical exam, I'm not going to bore you with this. You guys know, how to do a nice history of asthma. But for me, I always say the red flags are the big things that kind of I look for. Recurrent bacterial infections, wetness of cough is a big one. When a parent comes and tell me albuterol doesn't work, and I put some caveats on this because parents define doesn't work differently, right? Some parents are like, it doesn't work because it doesn't keep the cough away indefinitely. Like I don't give some albuterol and the kid never coughs again for the rest of the illness. Some parents define albuterol doesn't work as, no, it doesn't like abate the cough. It doesn't decrease the frequency. And it really helps to kind of tease out which one. And I spend some time kind of doing this in clinic. Sometimes I always tell parents albuterol should work in 20 minutes and it should last you 4 hours. That cough may come back, but it should slow down. And if the parent says, no, it doesn't do any of those things, then I start thinking, okay, is there something else that I'm missing here? If there's ever signs of hypoxemia at baseline, blue spells, having a hard time breathing, the kid is not sick, that's an issue. Respiratory symptoms even when well. If the kid's not growing, if there's belly issues, outside of reflux, and there's other belly issues, I start thinking about that. If something is persistently abnormal, I think the classical things for asthma is when the kid is great, or, when they're good, they're great, and when they're bad, they suck. When they're good, they run around, they're awesome, they're playful, and then when they're bad, they're horrible, and I think, that kind of, if the parent tells me, no, they're always terrible, okay, is there something else I might be potentially missing? If there's a sudden onset of stuff, like kid's been healthy, and then now the kid started wheezing at the age of 6, 7, 8, well, is there ever been a lead up, and then symptoms starting really early is also another red flag for me. When we think about severe asthma, the differential diagnosis for severe asthma, I break it down into these 6 groups. The first group that I always think about is what I call the dysfunctional breathing group. So you're talking about your kids with vocal cord dysfunction, inducible laryngeal obstruction, exercise-inducible laryngeal obstruction, the kids who are panicking or having panic attacks. And then I think about maybe, suppurative diseases, and these are my wet coughers, my kids who keep getting sinopulmonary infections, my kid who didn't ever really have a lot of illnesses, but then caught some illness and then for protracted bacterial bronchitis, and then now hasn't stopped coughing for 6 to 8 weeks. And then I think about anatomical. Is there something floppy? Is there some compression somewhere? Is there a fistula? Is there actually true pneumonias with this? Versus my interstitial lung disease kids who might present with oxygen issues, not growing well, everyday problems. And then these 2 categories down here, my other and my immune dysfunction, I kind of separated out because they're kind of my least common. These are immunodeficiencies, your connective tissue disorders, and then your other would be like congenital heart disease. And then chronic aspiration is another one. Is this kid somebody who's microaspirating for other reasons? Your diagnostic testing is as listed here, including labs, imaging, and then pulmonary function test. That's a big part of things that I look at. So now we're going to go through a bunch of cases. And again, if you have any questions, feel free to interrupt me. So we'll go with the first case. So this is case number 1, and I say sometimes it's just so easy. This was a 15-year-old girl. She had a history of recurrent seasonal cough. This was her first ever PFT with me. Her fractional XL nitric oxide was 81. And what you can see here is before albuterol. This is her pre-bronchodilator. Her FEV1 was 48%. Her FEV1 was, let me see if I can get this going. Her FEV1 was 48%, and she definitely had a low FEV1 over FVC. After albuterol, she had a 49% change. This was just very simple. Yes, you have asthma. And subsequently, she Symbicort, and ultimately, I think she ended up on Nucala. See if I can. All right, but then sometimes it's not. This one was a 6-year-old girl. She had uncontrolled asthma. Family reported chronic wheezing, chronic coughing, recurrent bronchitis. She'd been Symbicort 80. This was her first ever spirometry effort in clinic. So it was really easy to say like, hey, maybe she just doesn't know how to do it. If you look at her testing, her percent predicted wasn't terrible. I mean, she didn't blow out for a ton of time. Her forced expiratory time was 1.06 seconds. But honestly, she's 6 years old. I mean, that's probably pretty decent for a 6-year-old. If you use the Z-score, sometimes I just cheat and I tell parents, are you in the green box? And you can see, okay, your values are pretty normal. But this is one of those times where I think it's really important for you to look at all of the loops. And when you look at all of the loops, then you can see that this blunting right here is pretty there's definitely repeatability. There's a definitely flattening of her expiratory limb, and there is a concern for fixed intrathoracic obstruction. And I'm hoping that I can get this to, let me see if I can get this to play here. And what you can see on this reconstruction is that she has a right side aortic arch, has an aberrant left subclavian, and here, go back to the beginning so you guys can play. She has an aberrant left subclavian, and there's mass effects. And so essentially what's happening is she's being squished, and ultimately she was referred to surgery. So this is case number 3. This was an 11-year-old girl. She had a history of asthma. I had presented for a second opinion allergist who I work with locally. Mother reported, I really don't think it helps. I just don't think albuterol helps. She doesn't really have any allergies. She's always viral triggered. She had been put on, I think, some, ICS LABA. She was really inconsistent about it. Family really did not feel that she had asthma, and therefore they were not doing medications. They would often wait before starting treatment, or do green zone stuff very, sporadically. And to be fair, this was her first spirometry test, and you can see that she does have an obstructive component. It's mild, but there was no improvement on albuterol. And after our first discussion, it became very clear that what really the family needed to know was whether or not she had asthma. And this is where the benefit of a methacholine challenge is. And as you may recall, methacholine is a non-selective muscarinic receptor agonist. It leads to bronchoconstriction by acting on smooth muscles. It can also stimulate mucus secretion. And I often say, so there could be other false positives for this kid, but it's really nice to rule out things. And there are some contraindications, like if the FEV1 is too low, if the kids had other kind of heart issues, then we won't do it. We typically don't have to worry about pregnancy, but if there's positive testing, it does suggest asthma. And what you can see here is that within a first couple, she has a little bit of a drop. And then pretty much here she's at 10%. She goes up, she comes down, and then by 16 she goes to negative 54%. And for her, family said, the kid was like, yeah, this is exactly how it feels when I have an asthma issue. And this was really helpful because in this case, we said, hey, the likelihood is that this is truly asthma. One of the things I will mention is that if you were to order a methacholine from us now, you will see that this is based off of the old testing where there's a negative 20% change in FEV1 is considered a positive test. That's not what we're doing now. We are now using a PD20. So it's a calculation for the provocation dose that causes a decline in 20% FEV1. So instead of that big chart that you just saw, you'll see something more like this, where the child is given saline, then they're given methacholine in sequential increasing concentrations. And this is another kid who is another 13-year-old girl, was on smart therapy, albuterol and Singulair. And frankly speaking, this kid got a methacholine challenge because she didn't want to do her asthma meds, and mom got tired of fighting with her. And so essentially, I said, well, we'll do a methacholine challenge and let's see. And this was kind of helpful for mom to make her point. I hate to say it was that's what we did it for, but that's what we did it for. And what you can see is that she did have a drop here at her 4 milligram dose of methacholine. And when you actually calculate out, though, the PD20, there's a nice little table that we include in the methacholine challenge test. And so 75 would actually put her at mild airway hyperresponsiveness. And I think this is kind of one of the benefits of the PD20, whereas before we would just say, yeah, it's a positive test. Here we can say, well, it's normal, borderline, mild, marked, moderate, or marked. We kept her on smart therapy. She was perfectly fine on that. So here's another case. So this one is a 7-year-old boy. He had a history of asthma, was diagnosed actually incidentally at in a Somali refugee camp. He had been presented to the ED. He was actually hypotensive, wheezing. He had just moved to the United States a week week before the ED visit, had developed vomiting, fatigue, abdominal pain. In his ED exam, he was clearly having wheezy, but he was also hypotensive. They gave him fluids. They started him on steroids and albuterol. He had improvement in everything, and then was subsequently started on 5 days of pred and then sent home. He was to follow up. He followed up the next week, and in clinic, mom said he'd pretty much been on daily prednisone for asthma. And here's some interesting things, like, you know, his exam was really concerning to me. He was very thin, he was malnourished. He had just walked, mom was like, oh yeah, he doesn't breathe right because we walked from the parking garage to your clinic. And so our parking garage, you know, it is a little farther away, but we're only on the second floor. And he went on the elevator and he was having a hard time breathing and he was wheezing bilaterally. And what I became concerned was that this kid actually had had an adrenal crisis the week before because of the hypotension. So he was adrenally insufficient. And here was his first ever spirometry. And what you can see here on his FEV1, his percent predicted was 21%. He did not have an obstructive process here, but his FVC was 19%. He barely could blow out. And if you actually look at just this part right here, pre-bronchodilator, you could have said, oh, this is just severe restriction without obstruction. And what's important for you to note is that sometimes you're so obstructed that you can look restricted. Okay, so here's the albuterol response. He had a 78% change and just could not blow out enough before. And so therefore you'll see me do this as an interpretation, that the forced expiratory time does not meet the minimum criteria, and therefore we may be missing obstruction here. And so that's essentially what this PFT shows. And right after his bronchodilation, you can see his FEV1 got up to 37%, but it does not normalize. And so still is concerning for severe obstruction. And this then led to a CT scan, which I'm hoping to show you. So the things that you're going to be looking for on the CT scan is you see this heterogeneity in how there's areas of darkness next to area of lightness, and that is almost kind of a well-defined mosaic-like look to it. Here again, let me see if you can, I'll pull some of these here. So you see how there's kind of these edges to the darker areas and the lighter areas. So this, like, here's some mosaicism here. There's areas of ground glass. And there's areas of bronchiectasis right here. You see these big, thick airways here. Thick airways here. So this is a kid who had post-infectious bronchiolitis obliterans. And I think this is something that I think we should all keep, especially those of us who deal with severe asthma. I always say you need to think about this. Is this something that's possible? Typically, families will describe a kid who is healthy, then gets a thing, has a illness. And it's really hard because parents sometimes associate one time period and then everything after that. But if a parent is pretty clear, like, yes, I had a severe infection in childhood, it's typically early in childhood, and subsequently all of our stuff afterwards has been difficult. Subsequently, whenever we blow in spirometry, there's always airway obstruction. And then when you get the CT scan, you see air trapping, you see this mosaicism, you see this bronchiectasis, and then you have to make sure the kid doesn't have anything else, right? The kid doesn't have CF, doesn't have other reasons for bronchiectasis. And then you get the diagnosis of post-infectious bronchiolitis obliterans. It's interesting because in adults, they'll say, oh, you don't have necessarily albuterol responsiveness, but in pediatric patients, there is this, cases where they're reported that the child will respond to albuterol. It's just that the obstruction is not reversible. It is not normalized after albuterol. And because of this, we actually kept him on ICS-LABA. He's also treated with azithromycin Monday, Wednesday, Friday for post-infectious bronchiolitis obliterans. This is case number 5, and so this is a little bit younger. So I saw this kid actually in general pediatric clinic. So this is a 3-year-old with a second opinion for severe asthma. Again, interesting. I have a relationship with one of these outside allergists, and every time he has one of these kids, he just sends them my way. Again, same guy. And he had lots of albuterol needs. Mom was like, he just keeps using albuterol. But what's interesting about his story was that he was on Symbicort 160, and he was having problems just getting upstairs. I couldn't go upstairs, couldn't walk up and down without stopping. What's also another red flag was mom said, no, these symptoms definitely started before the age of 1. And he wasn't gaining weight well. He was having issues choking. And on his exam, he actually looked really normal when he was just sitting there. His lungs were very clear. But I make my kids do jumping jacks. I make them walk them down the hill, walk them down the hallway. And when you did that, you started noticing, okay, this is a kid who's retracting. This is a kid who's having DSATs. And so initially I was pursuing the choking issue, right? And so he had a swallow evaluation that showed that he had penetrations on formula, and he was having dysphagia. So subsequently, we ended up getting a CT scan for aspiration. And here is his CT scan. And what I want you guys to note is, again, there's these areas of ground glass opacity. This is the inspiratory, and here's the expiratory. You can see these, and this right here. Okay, we're going to stop it. Ooh, right. Sorry, guys. Right. You see that kind of bat wing kind of a look right here? Boom, boom. And go backwards a little bit. You can see this is on exhalation. You're going to see that this area. Now, when a child is laying flat, more often than not, those areas that don't aerate as well are typically in the back of the lung, not to the front of not anteriorly. It should be posterior. So this is a classic pattern for what we call neuroendocrine hyperplasia of infancy. And you can see this we call it this bat wing look right here. And that's typically the right middle lobe and the lingula. There's typically no significant bronchiectasis. And in a kid who had aspiration, you would imagine that the disease would have been posterior rather than the disease was anterior. This child had neuroendocrine hyperplasia of infancy, is a very commonly described childhood interstitial lung disease, something to kind of think about. Does not necessarily respond to asthma medications. I actually just saw him. He's 6 now. Prior to the age of 6, around 2 to 3, we actually had him on oxygen intermittently, and he is now subsequently weaned off of all oxygen. And if you're going to have a childhood interstitial lung disease, this is the one to want to have, because there's been no described deaths from neuroendocrine hyperplasia of infancy. They typically need oxygen early in life. They may have growth issues. They may have aspiration issues. They may have some sleep disordered breathing. They may have some allergies, but more often than not, by early childhood, things get a lot better. Okay, so step 2, identifying and correcting factors that make things worse. And so I kind of listed out all the different things that we typically do. And in my opinion, I think this is kind of easy to hard. So easy things that you can do is like, hey, make sure your asthma action plan's correct. Is your inhaler technique accurate? And then it becomes a little bit more hard when you start talking to families about environment. Stop smoking around your kid, improving the things that are inside the room. What are your allergen exposures? And then it gets, I think, treating other comorbidities. Okay, then it gets, and now this is the stuff I find the hardest. Talking to families, especially obesity-related asthmatics, about the importance of exercise, the importance of weight loss, adhering to mucus clearance if they have anything else that requires mucus clearance, and then also psychosocial. So we'll go with the easy stuff, and we'll talk about medical comorbidities. And I break this down by anatomically. So I say, what's in the upper airway? So your rhinitis, your reflux symptoms, your kids who have VCD or obstructive sleep apnea. Then your lower airway, other comorbidities that you need to think about. We were just talking, I think Jay Portner and I were just talking about a case of questionable ABPA. Is there some bronchiectasis? Is there bronchitis? Is there pneumonia? And then from a GI standpoint, I always think about eosinophilic esophagitis, reflux, also kind of in this group. And then the other is sort of obesity as other comorbidities. So this is case number 6. This is a methacholine, another case where a methacholine challenge was beneficial. This is a 12-year-old girl, third opinion, actually with difficult to treat asthma. She had negative skin testing, and her initial spirometry, which I don't show you here, was very short. Her forced expiratory time was very short. Her loop, there was no loops that were recorded, and in her, but overall her FEV1 was normal. She had, some facial eczema, but she kind of had these watery eyes. She had a globus sensation. She kind of chronically described stuff in her, throat and this kind of cough. She had been on 80, then 160. They'd been on Pepcid. She'd been on Nasacort. Really not very any improvement. She gets a methacholine challenge, and within her first, I think this is her second dose, she has like a negative 40% drop. Her PD20 in this case was 0.81 micrograms, so you can say that this is marked. But here's the part that was really helpful, actually. If you actually, the nice thing is with the methacholine, they always include all the other lips, okay? So in this kid's case, in addition to the fact that there was a component of responsiveness, there was also these kind of areas where her inspiratory loop was a little clipped and flattened here. And so it was really nice to use this because I first got to say, yes, we're on the right treatment plan. But I think the reason to why sometimes your albuterol doesn't work is because sometimes we're not treating dyspnea related to asthma. We're treating dyspnea potentially related to some inducible laryngeal obstruction. Here was another girl. This was an obesity-related asthmatic, and so she had a lot of other psychosocial kind of things going on, but her big thing was like she was really having problems with exercise-related shortness of breath, which was difficult, right? If she was a larger young lady, and she had actually had relatively normal testing on our first visit. Had been on some albuterol, some montelukast. She was put on Dulera 200 as a smart therapy, and pretty much blew through one inhaler in 2 weeks, just went through it. And in this case, there was a little bit of a debate in my mind of which one I should go with. Should I go with the exercise challenge? Should I go with the methacholine? And in this case, I ended up deciding on the exercise challenge because she really did feel like her symptoms were exercise related. One of the things you should see in this exercise challenge, she didn't really have any changes off of her base, nothing really significant you can see here. But again, this one was nice because we could take a look at her loops. And again, as you look at her loops with exercise, even before on base, you could see this flattening on her inspiratory loops. And I always fall into calling it clipping, though I think now we call it flattening of the inspiratory loops. And in this case, I talked to her about exercise-induced laryngeal obstruction. And for her, I actually took her off of a SMART plan because I did not feel that she had the ability to differentiate between when she was having dyspnea from her BCD and when she was having dyspnea from her asthma. And then, so when would I use a bronch? And I think this is kind of helpful to know. So this was a 15-year-old with trisomy 21, really unreliable PFTs. She was on Dulera, also 200. Mom thought maybe some responsiveness to albuterol. And I always say, you know, with trisomy 21 kids, it's very difficult because trisomy 21 kids always have some hypotonia, right? So exercise and fatigue-related exercise makes sense. I mean, you know, if some of, you know, it's harder for them, and it can complicate the diagnosis of asthma. And it was really, you know, mom was like, I don't want to give her something if it's not really going to be helpful, right? So we ended up doing a scope, and this is her actual pictures. So this is flexible bronchoscopy, and what you can see is we call this fish mouthing, this kind of flattening, kind of this wide flat trachea instead of a nice upright U shape. And here again, you can see how the airways, they kind of have this like flatter, wider look to them. And so ultimately on the actual camp video, you could see that her whole posterior membrane would rise up and kind of everything would collapse down on each other. I ended up calling her tracheal malacia. What are the important things to consider when you say, hey, I'd like to, you know, send a kid to you to see if you can get a bronchoscopy? Well, there's not a lot of reasons, in my opinion, to do a bronchoscopy. I love to do them, but you know, one of the big things in asthma is, okay, do you want to do it for phenotyping? Like, do you want to do a cell count looking for eosinophils, neutrophils, or just say if this kid is posse immune? There are some caveats there, is that, you know, we know that eosinophils are very responsive to steroids. So is there going to, what happens when you have a kid who's on high doses of ICS and looking at those cell counts? I think personally for me, I find it more beneficial for an anatomical evaluation and ruling out other things. And as a reminder, for phenotyping, remember that in blood, you know, blood cell counts are very different than BAL cell counts. BAL cell counts, there's a lot more macrophages. That's the predominant cell, over 80%. And there's same as in blood, there's not really that much eosinophils. And to the comment of phenotyping, I think you guys typically have more conversations about this separately, so we'll get into this a lot, but I typically try to say, is there eosinophilic or non-eosinophilic, and then trying to separate those two out within my clinical group, my clinical cohort. And then so in eosinophilic asthma, I typically say, you know, these are typically my more early age, my allergic kids. They're thought to be more steroid responsive, whereas I think my non-eosinophilic asthmatics, like, you know, my neutrophilic asthmatics, are these kids who are triggered by environment, air quality, pollutants. It's been reported in all ages, not just in early school age. Whereas in my posses, I think, okay, like what could be potentially the reason? Is this because of smooth airway muscle cells are different? Maybe they proliferate differently. These may be smooth muscles that are more responsive, and there's not necessarily an inflammation component to this. Again, let's talk some more about comorbidities. So this one is case 9. He's a 17-year-old. And so, and this is a good example of like acute onset things that are weird, right? So this kid, the day before had gone to his doctor, had a well child check, was doing great, cleared for sports, plays football, is a huge linebacker, looks very healthy young man, was in having lunch with mom. I think had a sandwich of some kind. I can't remember, it was tuna or something like that, which mom was like, I don't know, like maybe it was tuna. And then subsequently developed acute onset respiratory distress and pneumomediastinum. Ended up being intubated, sent to the ICU, was on IV methylpred, and, you know, was able to be extubated and weaned to room air very quickly after initiation of steroids. Past medical history was significant for shellfish allergy. He did have intermittent cough and cold with exercise. And mom did say, no, once a year he does cough for a long time. But we just thought it was just his cough. you know. And so the differential at that time was, is this underappreciated asthma, or was this true reactive airways dysfunction syndrome? So if you ever meet any of our pulmonologists, we're always very clear. We don't believe in reactive airways disease, but reactive airways dysfunction syndrome is real, okay? That's the exposure to something that then causes a reactive airways shutdown or obstructive component, but typically an exposure to something, some chemical, some some kind of, irritant in the air. We sent him on steroids. I went ahead and I started him on some Symbicort. I told him to follow up. Within 2 weeks, he has worsening doses. As soon as we start tapering him off the high dose stuff, he goes to an ER. The ER says he has bronchitis evolving into pneumonia. They start him on IV ceftriaxone. They send him home on some Augmentin, and mom was not happy with this, and so essentially, like, literally showed up in my clinic, knocking on the door and said, "Can I see Dr. Tam-Williams?" And I was able, thankfully, to fit him in that day. And he said, I was fine, but then the thing is that I was coughing up these worms. They look like little 1-inch long worms. They were about as long as a spaghetti. And before that, I had actually coughed up blood for about 1 day. So this is his CT scan of his pneumomediastinum. Nice, really pretty picture of a pneumomediastinum, but you don't actually see nothing here down below. And this is a CT scan a week later, and I'll try to see if I can get it to stop right where, oh no, keep going. Right there. Do you see how this whole wedge here is off? Right here. So this was concerning to me when I spoke to him, and then also on the CT scan of plastic bronchitis. And I had concern that he had actually had cast plugging. We had a CBC done that had high eosinophils, again off of steroids, and the casts were concerning. And ultimately, he was actually started on mepolizumab in order to wean him off of oral corticosteroids. And we had ended up diagnosing him with asthma and eosinophilic plastic bronchitis. All right. Case 10, this is our 10-year-old. First visit, and this I want to use to emphasize kind of time as part of our evaluation of severe asthma. So I met him when he was 10. He had clearly very severe eosinophilic atopic asthma, lots of shots, lots of oral steroids, IM steroids by his PCP, multiple aeroallergen triggers, mom smoked at home, the whole thing. I started him on mepolizumab, and subsequently he was much better. Less visits to the ER, a lot less steroids, but middle school gets really tough. He ends up ultimately with a diagnosis of ADHD, ODD. The family dysfunction was so severe that mom essentially had him living at grandmother's house because they could not get along. And one of the things that you start seeing is that he was relatively high, and then he starts doing this kind of a thing. And this is after albuterol, and then this kind of a thing again. And he has this worsening trend. And essentially after about a year or so of me banging my head, he finally comes and says, "You know what? I've been vaping. I've been doing, THC and nicotine pretty much for the past year. And, I'm not going to quit," is essentially what he said. So I think this highlights some of the things that are the most difficult comorbidities, and I call these the psychosocial comorbidities, and I break them down to the intrinsic to the extrinsic, and the intrinsic being anxiety, depression, ADHD, autism. I mean, even ADHD, any of us who know, managing, how do you get a kid with ADHD to remember to do all of their medications in the morning is a real chore. Anxiety and depression, we know these are prevalent in severe asthma. We know they can also worsen symptoms as well as control. And I always give the example. I have one family that I remember one time she was yawning in clinic, and I always mess around with my kids, and, she just kept yawning, and I said, "What's going on? Am I boring? Like, what's happening here?" And on further history, Mom said, yeah, she sleeps terrible. I mean, she's a horrible sleeper. She's up all night. She doesn't go to sleep. And, I kept pressing her about it. And ultimately she said, well, I have a hard time falling asleep. Well, why do you have a hard time falling asleep, honey? And she's like, I'm worried that I'll die in my sleep of my asthma. So she was essentially keeping herself up all night, with these anxious thoughts, fearful that she was going to pass away from asthma in the middle of the night. And for her, a big part of my severe asthma management was getting her to our psychologist and getting her on anxiety and depression medications. And then what about those extrinsic things, so environment things, as we know, air quality, air pollution, stress, that's a whole talk all by itself. We talk about poverty. You have one of the biggest advocates for adverse childhood experiences and like the importance of that within your department, so recognizing the links between poverty and asthma, recognizing that children with ACEs and asthma, who are Black or brown in particular, have much higher risk of asthma than children who have no ACEs. And these ACEs can include all of these different things that are here. And then lastly, the things that I talk about, culture, how your family views asthma and asthma control may be very different than how I view asthma and asthma control, and how that can be a limiting factor and something that needs to be overcome in order to really improve patient and physician interaction. And so lastly, I think this kid, emphasizes truly how the management of pediatric severe asthma can change over time. So he was 11-year-olds when I first met him. He had been in the ED 19 times in the previous year, was clearly atopic, had been admitted to the ICU for BiPAP. And in one of our first visits, we started off with the basics, ICS, adding in Spiriva. And then subsequently, he'd been started on Xolair. He failed that quickly because he became anaphylactic. Started him on mepolizumab. And during that time, it was still not well controlled. So we ended up assessing him for reflux, vocal cord dysfunction, which he was like, I still remember that visit. He's like, Dr. Jade, that's not my problem. I'm anxious because I can't breathe. So I said, okay, fair enough. He had an environmental assessment, which showed that he had mold in the basement, and family actually ended up moving homes because of this. He continued to have poor control despite being on mepolizumab, so I took him off of that. And then he ended up developing iatrogenic adrenal insufficiency because he had been on so many courses of steroids. He was on Dulera 200. And ultimately, I moved him to benralizumab. We actually, because of his adrenal insufficiency, I added in ciclesonide. And I think at that time I couldn't find a Dulera 50, so I kept him on a Dulera 100 with a ciclesonide and airway clearance. He had developed a very mucousy component to whenever he coughed, and this ultimately was his plan. And most recently, we graduated him from high school on this plan, and I think this really overall kind of improved his quality of care, quality of life. And I know we won't have much time, and I was going to briefly talk about treatments, but pretty much I'm not going to, because I know I only have so much time. But this one is one of my favorite for the fellows. Is one of my favorite kind of papers. It's really just came out. It's a nice one. Targets of biologic therapies. I get that question a lot. How do I choose which one from our fellows? I think this is a very nice paper that kind of outlines, which kids you would think about doing. I think the only thing I don't use is resolizumab, but all the other ones we do use in air. And then his is again from that new gem paper. And then lastly, with one of the treatments that I want to just touch base on, because I'm not going to talk about ICS and all that other stuff, is going to be macrolides. Typically using macrolides for those with what I say not TH2, or sometimes neutrophilic inflammation, and it has been suggested to use for Monday, Wednesday, Friday in those without evidence of Th2. These guidelines, to be very clear, did not apply to children, and it was unclear efficacy. There was some Cochrane reviews of this that were, of course, essentially said what I feel like a lot of Cochrane reviews say, which is like, well, we're not really sure with limited confidence, but it didn't hurt, you know. There is a recent randomized control trial of children between the ages of 5 to 15 with poorly controlled asthma, and they used 10 mg per kg 3 times a week. And for those, it was an N of 120. They did have improved asthma control tests, and they felt like there was a higher proportion of children with better control. They've also used azithromycin for viral-induced wheezing, so right at onset of a wheezing episode, in order to prevent worsening or more severe episodes, and that has also been described. So I do have a couple of these kids that are also on macrolides for this reason, so I want to make sure I touch base on that. And then last is, if you ever want more in-depth approaches, these are two nice references that I like to use. And then finally, I always talk about, this is my real life versus ideal life slide. What's the issue with control? There's the issue of control as an intrinsic factor. I have underlying bad asthma. Okay, I have bad asthma intrinsic, but then more often than not in air clinic, at least what I find is that it's extrinsic factors that are the issue, right? And it is because they have this interplay of biological, psychological, environmental, social factors. They're not adherent for a number of reasons. And the treatment plan is too complicated. There's significant financial strains, and there's secondary gains. I get to miss school, etc. And then finally, from an extrinsic factor, I was talking about being one-armed by insurance. What would you pick if you lived in no insurance land? I always have that, what would I do if this kid never lived insurance? And then I don't know if you guys ever seen Dr. Glaucomfecken, but I'm going to end with this lovely video, and I'm